So for me, I'm looking at Stuart's shoulder, and in terms of having anterior shoulder pain, there's a fair chance that these structures are lengthened, aren't they? So if you're having shortening through the front with most shoulder problems, what happens to the structures in the back?
They must actually extend it a little.
They lengthen, don't they? So they're pulled into a lengthened position. So when that happens, what happens to these muscles when they get lengthened? So if I was to replicate lengthening, like so, what happens?
They go forward.
Well, they go tight and they like to bind down onto the underlying structure, don't they? So superficially, before we start worrying about any deeper structures, we should try and clean up any myofascial tightness, okay? So the traps is obviously going to be the first port of call, aren't they? So we have our traps coming out here and then down here to T12. So for me, pardon me, for me I want to lift, okay, traps away from lats, okay? So it's pretty stock standard. I've been doing this for a long time in terms of myofascial release. So we're all familiar with engaging the fascia and so forth. So I'm picking up the lateral border of traps, especially down in the T12 area. I'm going to do it either digitally this way, so I distract it as much as I can transversely, then I go longitudinally, okay? And the technique is not lengthening the fascia, it's lifting, okay? So there's a difference. We're not working to lengthen this area because it's shortened. We're doing it because it's lengthened. So therefore we want to lift, okay? So I'm just coming along this lateral border. Now, as I come out more laterally, I'm starting to pick up over the rotator cuff. Okay, so you're going to pick up a little bit of, what do you think, fascia of the infraspinatus and a bit of teres as well, aren't we? You all right there, Stuart? Okay, so I'm doing that digitally. You can, if you like, engage it with the forearm. I'll just go through this process. So you're just picking up a larger amount here. So it's very slow. We're not trying to slide. I mean, everyone's familiar with myofascial tension techniques, aren't they? If you're not, then it's all about engaging the tissue and not forcing it. So I'm not trying to push through it. I'm just letting it all deload. So I'm applying a load to it. Okay. Now, if the lower part of the traps are in this lengthened position, what do you think happens to the upper traps?
That must have been shortened.
Do you think? Okay. If these lower traps aren't working, what happens to our upper traps? Well, what happens with most people?
They're contracting.
Well, they overload because we use them. Okay, so, and hence the reason of...
Isn't it where he had the injury, so they obviously they had to be contracted or overloaded?
Well, no, he's more anteriorly. Yeah. So what we're going to do is going to bring him up into a bit of abduction, pick up his traps, and we're just going to do a little bit of longitudinal gliding just to desensitise these traps. Now I'm saying desensitise because if he's quite irritable through here, that's all we want to do. We're not worrying about deactivating. Okay, everyone's familiar with the process of desensitise as opposed to deactivate. So if he's really tender in here, and let's face it, there's a lot of people out that come into our clinic that are very sensitive in the upper traps, then this sort of work is absolutely excruciating, okay? So I'm applying a load that he can handle. Is that correct, Stuart?
Correct.
Because if I wasn't, what would we be doing? What would we be seeing?
Screaming at you. Might have been here too.
Well, he'd probably be lifting off the table, wouldn't he? Yeah. Look how red he's come up here too. Bit embarrassed, eh? Okay, now that I've desensitised, now I want to lift the upper traps up and away. So what happens with this trap fascia, this anterior, binds down onto the clavicle itself. So I want to lift it up and away. So all we're doing here is just clearing out all these superficials as best we can. So I'm using finger like so, wrapping around to the anterior portion of that traps. And then what I'm doing is bringing the tissue back this way and then applying a load diagonally, okay? Like so. And now what I can get Stuart to do as well is, I'll do this sequence, is now, Stuart, can you push your scap in towards your spine a bit? That's it. And then depress. So now I've got him in that position where he's switched on his scap stabilisers. Okay. Now I'm going to treat him. Now can you hold that there? How are you going here, Stuart? Okay, good. All right, relax. All right, come in and just do a little bit more desensitising. Now, if Stuart was a throwing athlete, I probably would have spent a fair amount of time just quickly assessing his hip. And why do you think I would have done that? And his lumbar spine?
Because the whole body would have been affected.
Okay, because most throwing athletes
because of the twist.
use their hips, okay. And that would have brought in all his lat dorsi fascia, QL, and then possibly even his external obliques, okay. But because we're not treating a throwing shoulder, I'm not doing that, okay. All right, now that we've done that, let's visit some of the rotator cuffs. So, in particular, no, infraspinatus. Okay. Whoop. So, into a bit of adduction and then through abduction. Okay. So working it through a variety of range. So I'm just doing this passively. I'm engaging only digitally with the thumb, and I'm following the line of the muscle. Here we go here, Stuart. Now I'm just going to wind up the range a bit more. Okay. Just take a little bit further. So we're just bringing longitudinal glide. It looks deep pressure, but it's not that bad, is it, Stuart?
No, it's fine.
And it's more just depth versus speed with it, okay, as opposed to working deep, hard and fast. Right, so I'm working with the tissue and the range, so taking it through range. Range of abduction, not external rotation. Okay, good. Now, if Stuart had had some infraspinatus signs on, so he's resisted external rotation, then this would be an opportunity where we'd get him to do resisted external rotation and pinpoint where he feels it, okay? And then we could work on that area. So treat and trial, treat and reassess, push up again, better, worse, same, okay? All right. Okay, so now I'm going to work, and it will be no surprise to you, pec minor.
Okay.
Minor.
Yep.
Okay, so, sorry, because I'm going to
No, that's
stick
all right.
my... That's why adjustable table is good, because it's just bring it up and... So, we don't have one, so I'll bend my knees. Okay, so now this will be different, obviously, for a female, because of the breast tissue, so we'd scoop up and around it. But because he's male, we don't have to worry about that too much. So to engage pec minor, now if we find that someone's actually quite tight fascially in and around the pec area, arm comes up into abduction. Put a bit of lube on there. Your choice. Now, thumb is going to go underneath the scapula, and we're going to go towards the axilla, all right? But we don't go into the axilla, all right? But we're going to wrap around the posterior, okay, fascia of the scap, which is the posterior auxiliary fold, correct? So we just roll in until we feel resistance, okay? Now, when we get to this point, you're all right there?
Yep.
Yep. Bring the shoulder down, okay, close it off, okay? So now everything there has now what? Shortened, but also relaxed, okay? Bring the other hand over the top of the glenohumeral, and then just slowly push down on the shoulder, and with this arm, roll in, okay? So we're doing that,
So
okay?
like almost lifting top of me.
So you're doing this, all right? So I'll do it again. Down, relaxed, I'm engaged. I'm not trying to push my thumb into the other side. I'm just engaged enough that he can feel it. And then I'm pushing down and rolling in, okay? So I'm in there now. All right?
Yep.
You happy? That's
Oh,
all right?
always, always.
Okay. That's not too much? No, that's okay?
It's good.
Okay, all right. So now that I'm in, now that I can actually take it through some range. See how I'm in there now? Okay. Now it's at this point where if you take it too far, it'll push you out. All right, so you need to take it to the point where that doesn't happen. Now you just relax on it. All right, so now we have the arm in this position. I bring the other finger over the top to just reinforce, okay? So now instead of, now with subscapularis, I'd say, and I was taught this, most of the time it was in that lower portion, sticking your fingers into that lower portion of subscap. I go for the upper portion, all right? I just find it so much more effective. So now, braced with two thumbs, engaged, I then now bring it into abduction and abduction, and just working through that upper portion. Here you go, here, Stuart, just talk to us as we...
Beautiful.
Oh, hey, we've played him. Now, at the same time, what I can do is then bring the arm out and then into external rotation as well. Okay, so what I'm going to do is I'm going to engaging that way, and then a little bit that way, and I'm going to get Stuart to just go to in and out of internal and external rotation for us. That's it. Just backwards and forwards, nice and slowly. And I don't necessarily want him to go. That's it. To the end of the range either. Just has to go through it. That's it. Good. Subscapularis. There you go, here, Stuart.
Yeah, good.
Okay, all right. Now, This is also very important. Same way you go in is the same way you come out. All right. Don't just try and pull your finger straight out. All right. So take the time to then close it over, and then gently and slowly come out. All right. I only say that from personal experience. Try that one. Go like that. Sorry?
What about if you pull your finger out? What happens if you pull your finger out?
Oh, it's just very uncomfortable. Yeah, I'm just thinking of patient comfort and so forth. All right, so we've done pec minor subscap. Now I want to just work a little bit through this anterior fascia, superficial fascia. Here we go, there, Stuart. Good. Good. So now as we go through, I'll do one sweep. Now, the next sweep, I'm going to put my finger underneath here. Right, I'm going to get him to relax. Relax. I'm going to get him to switch on his scap stabilisers again now. All right, so in and then down. All right, you got that? Hold that there. Now I'm going to work this fascially again with these scap stabilisers on again.
What will that help you achieve, Stu?
Well,
doing that?
because you'll find, because he had that happening, when I switch on his scap stabilisers, well, if you switch on your scap stabilisers, it brings your shoulder back and down.
Yeah.
Okay, now when you do that, it's not unusual that most people will actually feel like a tightness through there. And in actual fact, I probably, depending on how bad they are, I might tape them in that position. Okay, so to when they go home, so I'll get them to switch on their scap stabilisers, just run a tape from the at the anterior part of their glenohumeral and over down across into their traps. And so when they relax, they feel a pull there. Mm-hmm. So the exercise for them to do is to bring back and down, but they've got to do it over and over again, okay? It's not the tape pulling it back and holding it back, it's the actual, you have to contract and relax so that you take the pressure off here. And that's sort of what I'm doing here with treatment. So I'm trying to put the fascia in a position where I'd like it to be and then work it in that. And I'm going to do the same thing with pec minor again too.
Okay, so are you sort of saying it's almost a bit like re-triggering, almost like the memory in the process of going, stay like this?
Yeah, it's got to happen over and over and over and over again, okay? You can't just retrain the posture with a couple of simple exercises. It's got to happen over and over and over and over until that actually changes. So it's the brain telling the muscle that we need to change. Well, how come we're doing this? How come? And that's the whole process of, well, as far as I understand it anyway, adaptive shortening.
Mm-hmm. So is that hurting at all, Stuart?
No, not me.
You wouldn't want to do it on a Friday night, but no, it's fine.
What level 1 to 10?
7.
Okay. All right, relax. So it's same again, switch on your scap stabilisers, down, good, hold it there. And then I'm going to once again go through pec minor again with them switched on. So what am I doing here? In the overall picture of things, what am I actually doing? You want to hazard a guess?
Relax the muscle.
Yeah, I'm trying to, from a soft tissue point of view, help the muscle imbalances. Okay? That's all I'm doing at this stage. I'm not treating his pain, I'm just helping with the muscle imbalances. That's all I'm doing. All right. So we know flexion, he had some restriction. So let's just wind him up into that. So how's that feeling now, Stuart?
It's fine.
Feels okay? If we wanted to, and if he still did, the idea is we would look for it. So whereabouts do you feel it? If he says it's here, then we deload from here down to there. So let's just say that he says, I feel a stretch through here, okay? And so we're picking up, well, a bit of serratus anterior, aren't we? Pick up the arm, and then just slowly work through again. Well, at this point I'd be asking him about life and family and his job and footy, and it's never this quiet in treatment.
So is that tender through the pecs?
Yes.
Yeah.
So it's here that I'm actually working through. So that's serratus anterior. Okay, now, given the fact that we've worked through most of the muscle imbalances, well, the major ones anyway, now I want to treat his pain. Okay, so he had pain on resisted. Where's Dave? Is it David?
Yeah.
Yeah. So you've got all the, remember off the top of your head? Because I'll have to. All right. So resisted flexion. Okay. He had pain anteriorly, didn't you? Correct?
Yep.
Okay. So just pushing up against me. All right.
During the lower and upper.
Okay. All right. Go again. All right. And again. You feel any pain on that? Whereabouts are you feeling it?
Slight pain on the last one.
Slight pain on the last one there. Okay. All right. So this is where we treat and reassess. Okay. So I'm coming in. So he's feeling the pain there. So I'm coming just below it. I'm going to work up towards it. How you going there, mate?
Good.
Good. Is that about it there?
Yep.
Okay. So now we're just going to do, what would these be called? Bit of cross fibre, you could do some DIP, you can do some fascial work, whatever tickles your fancy. As long as you hit the area of the site. Cross fibres do what? Yeah. Do they? Yeah. Well, they help with pain perception. They reduce pain perception. They also increase fibroblast proliferation. So if we were talking of something that's falls into that category. Okay, good. All right. You ready?
Yep.
Push up against me again. And again. How's that feel? No pain? Now, let's just say, I mean, we'll go through all the range of movements and deactivate those. But let's say there was no change, okay? What do you think that would mean? It's not where the problem is it? Okay. If it was worse, what would that mean?
You just aggravated it.
I just aggravated it, didn't I? It's very sensitive. So we would do what? We could do that, absolutely. But we wouldn't work the site, okay? So, instead of saying that, we wouldn't be as aggressive. So we would desensitise, okay? So be lighter pressure through that area, whereas before I was engaging and working across it, so it was quite aggressive, okay? So always ask, is it better, is it worse, or is it the same? And they're your decisions. If it's better, you continue, okay? If it's still there. If it's worse, then you back off, okay? Work conservatively. And if there's no change, change sites. Try and isolate. Okay. Now, that's great that you got no pain, but usually you might find you'd have to do a series of maybe 5 of those sort of approaches, okay, where things just tend to desensitise or deactivate, which is great. Now, resisted abduction, David? Yes?
Abduction, resisted, left side was strong, no pain, right side was weaker, about 110 degrees pain on the right.
Okay. Okay, so all right, so pushing up against me. And one more. Hang on, I was off balance.
Is there a chance that he could be re-aggravated by the by the resistance?
Yeah. Yeah.
I'm just wondering whether,
But the idea is I want to test him in all the ranges that he was positive in.
Yeah.
And if we can deactivate all those, because, yeah, subscap is the one that I'm most interested with him, but I guarantee there'll be other.
I just wonder about the degree of contraction.
No, I want to wind it up until I actually get a positive sign. Treat it and see if I can make a change. So, yeah. So push up again, Stuart. Any pain on that? So feeling it there, all right. So the idea is that I'm just clearing out the different ranges of movement. I've cleared out flexion, now I'm doing abduction. Is that your stomach?
Yeah.
Stu, do you have any suggestions for the strength testing, the active testing? Because speaking from personal experience, I have had doing a lot of the resistance testing, and it just did aggravate.
Yep.
For
Push up
me
against me.
personally.
Yeah.
And I think if I did that much testing with someone who had
Go
a
again.
very sore shoulder, that I would be aggravating it. So do you have any suggestions?
Yep,
for how to
because
get around
that would fall into, as I said before, probably someone who's highly irritable. So
then
they
you
would fall into the category of being irritable. And you probably find that this sort of treatment, like the first bit you do, probably make it worse. You know, they'd go, oh no, I really feel that. Do you know what I mean? So then you know, oh right, okay, I'm dealing with something that's a little bit more sensitive. And that's, but that's the point I'm trying to get across. I'm able to do this okay because, as I said from the outset, giving his signs and symptoms and his history, it's a mild irritation, so that's good. But if it was someone who was easily aggravated with resisted movements, then you would back it all off. Yeah. And then take that approach later on down the track.
And your treatment would be different too, like you do more longer strokes.
You would do your longitudinal, you do all your venous type strokes, you know, your desensitising strokes. You wouldn't necessarily engage the sensitive sites, you know, yeah. And you will know straight away because they'll, oh God, that's worse, you know, so there's your rule of thumb. Okay, push up against me. And again, how's that feel? Better, worse, same?
Better.
Okay, where are you feeling it? So what I'm doing here is I'm slowly chasing it now. So I've moved off the original site, now I'm going around a bit further. So now I'm coming towards, well, almost supraspinatus. Has anyone had ongoing shoulder problems? Yeah. Anyone else? Yeah. Geez, that's not many. The rest of you must be doing really well.
I would have been a big no worries.
Yeah. I did a presentation for Sports Medicine Australia, and it was for physios. And I said, how many people have had problems with their shoulders? And they're all like,
Oh no.
yeah. So it's, okay, go again. Okay, how's that? Okay, so going down. What was that?
The ultrasounds don't take that much effort. I'm only joking.
They're not all like that, really, are they?
You know, that was just a joke. You know,
Yeah.
this is the part of the treatment.
So I'm over the supraspinatus attachment now, and that's usually really nice. Are you getting any referral with that?
No,
That's all right, just sensitive there?
just like
Yeah, okay. Push up against me again. And so you can sort of get the idea now. I'm just retesting, treating, retesting, and going through all the ranges of movement.
How long would you normally spend on a client that come in with something like this?
Well, yeah, no, that's a good question. If it was initial consultation, then it would be an hour. If it was sort of standard, I'm doing a follow-up, it would be about 45 minutes to half an hour. So it would vary depending on the person, yeah.
So, Stuart, what is the actual cause of his shoulder pain?
The big question, isn't it?
Because you reckon it's subscap.
No, I think a large part of his problem is subscap,
Yeah.
but there's so many other influences,
Yeah.
okay? And I think, well, I hope, that's what I'm trying to get across tonight, is that it's not subscapularis tendinitis. Well, subscapularis is definitely a part of it, do you know what I mean? And it seems to be more of a problem than any of the other rotator cuff muscles, so that's been my focus. Had it been supraspinatus, which I had more supraspinatus signs and, you know, I had the referral down here into the deltoid insertion, then that would be my focus. I haven't touched his supraspinatus at the moment.
Right.
Do you know what I mean?
Yeah.
Because, I mean, I could and I would, but it's not the focus. It's subscap that has been. So the idea is I retest him and see if he's better, worse, or the same. And that's
But what I'm getting at is,
Yep.
is that to date, you're
Yep.
only getting relief with the latter part of the treatment that you're doing.
Yep, the last part of my
Yeah.
treatment is focused towards his pain-producing movements.
So you won't get relief without working those structures and just working
Oh,
the
no,
subscap.
no, I wouldn't say that.
Oh, okay.
It may not be as effective, but I'm not saying it's not going to be effective. Yeah, definitely not, no.
So it's like treading the shoulder as a functioning unit.
Spot on.
That's different,
Yeah, and you'll find that's in the notes. It's treated in its functional, well, that's about as functional as we can get apart from them actually doing the action that actually aggravates it. So if it's a throwing athlete, and I do with throwing athletes, get them into the throwing picture and doing it and saying, right, where are you feeling it's there? Okay, right, let's get you back down, let's treat it, back up, right, now throw again, where do you feel it now? Has it changed, has it moved? Whatever the case. The other picture to this as well is whether or not with shoulders and the upper extremities, which we can do a great deal with, is the thoracic outlet syndrome. Okay, so we're, from a soft tissue point of view, if we're looking at obviously scalenes, pec minor, the neurovascular structures are flowing through those or underneath, they're getting paresthesia. Then the process that I would take then would offload those, offload scalenes. Probably you find you'd have a first rib situation, pec minor, and then I take him through into, is everyone familiar with upper limb tension tests? So the neural stretches, yeah, the neural tests, okay. So you take them through which is basically just a neural stretch, and there's different variations depending on the nerve. Take them through the range. Okay, so this isn't like a nerve stretch. So just tell me when you start to feel. Okay, now where are you feeling that? Okay, so he's feeling it here. That's where I treat. So I get him back down here and I work through that area. Okay, myofascially. Probably do a couple of sweeps. And then back up again. Okay, head over there, depress, back down again, just relax, I want it out. Just tell me when you start to feel the stretch again. Whereabouts are you feeling it? About there. So you'll notice that we can go a little bit further now, but now he's feeling it here. So we're just chasing wherever he feels the tension in that nerve stretch, okay? Because we're winding up the nerve and the fascia.
So there were at least one segment of the other parts become exposed that might have been
Yep.
a little bit more silent. That was the most obvious part.
Yep.
This one is
You'll
very
find,
clear.
and I usually find, you'll plateau out at one area, which will be the main culprit. Well, usually. Now the object is to get full range of movement of him, so he can do that without a stretch, without a deep neural stretch. So tell me when you're starting to feel it, mate. About there. So where are you feeling it now? Down through there. So we're just chasing this. Okay. So everyone sort of get the idea. And just relax again. So the idea is I want to get him locking out. Where do you feel that now? Okay, so he's now feeling it all the way down here. Okay? All right. Has anyone got any questions?